Welcome everyone, and thank you all for coming tonight to the first of a series of 3 and possibly 4 webinars on obesity management, brought to you by obesity doctors in the ACT and the Capital Health Network. Tonight's topic is the physiological and psychiatric basis of obesity. I'm Dr. Leonie Harcourt, the GP advisor at the Capital Health Network, and also with me tonight are Dr. Richard Singer and Dr. Louise Brightman, as well as Kunal Mohuti from Capital Health Network. So first of all, I'd like to start with the acknowledgement of country. So we acknowledge the traditional custodians of the land we are meeting on, the Ngunnawal people. We acknowledge and respect their continuing culture and their contribution they make to the life of this city and this region. We also acknowledge and welcome other Aboriginal and Torres Strait Islander people who may be attending tonight's event. So we always have a bit of housekeeping, so here it goes. All participants have been muted. So if you have any questions, please type them into the Q&A section on your Zoom panel, and we'll try and answer them at the end of our question and answer session. And we do love questions and we love to chat. So please feel free to put in anything you like. Copies of the slides will be sent to the participants after the event, and also the evaluation survey, which is critical if you want your CPD points. The video recording of the presentation will also be available on the Capital Health Network YouTube channel if you subscribe to that, so you can watch it again at your leisure with some popcorn. So tonight's event has been accredited by the RACGP for 2 hours of CPD for educational activities. And you can we can upload those hours for you. So Capital Health Network can upload those hours for you if you give us your RACGP number and also complete the post-event evaluation survey. So those are the 2 critical things if you want Capital Health Network to register the hours for you. Otherwise, you're very welcome to self-record them on your own dashboard. So we'll also be posting some questions throughout the webinar. So if you've done the pre-reading and also answered the questions, you can self-record an extra 30 minutes of reviewing performance to your CPD dashboard. So all up, you'll get potentially 2.5 hours from tonight. And if you register for the subsequent 2 webinars, they'll give you another 2.5 hours each, which will be 7.5 hours. And then if we do another webinar, a 4th one, you'll get 10 hours through the obesity management series of webinars for the 2023 CPD cycle. Okay, so enough of me talking and over to our presenters. So first of all, tonight we've got Dr. Richard Singer. Dr. Singer is a renal physician with certification from the Strategic Centre for Obesity Professional Education, or SCOPE, which is the gold standard for obesity management in the world. Richard works in the renal unit at the Canberra Hospital and in private practice at the Respiratory, Sleep and Comprehensive Internal Medicine Clinic. His main interest is in kidney disease and nutrition, and he is the medical lead for the Canberra Hospital Renal Weight Management Program, focusing on assisting patients whose body weight is seriously affecting their kidneys or where excess body weight prevents kidney transplantation. Okay, so over to Richard.
Thank you very much, Leonie. I shall now try to do the right thing with sharing my screen. All right. Well, thank you very much, Leonie, for that kind introduction. And I've been asked to talk about the basis of obesity. And I thank the Capital Health Network for inviting me to give this talk. I think it's a very important topic, and it's quite an interesting topic as well. So the objectives of this talk are to help you gain a better understanding of the causes of obesity, of the lifestyle factors that are associated with body weight change. So that's both an increase and a decrease in body weight, and to gain an understanding of body weight set points, which are a very important concept in obesity management. But before I get on to that, I'd just like to address obesity stigma, which is a very common occurrence, both amongst people who have overweight or obesity, as well as in the general population and in many health professionals. So obesity stigma is blaming the person for the disease, and we do it sometimes for other diseases as well, but obesity gets a lot more of it. Now, the difficulty with this when patients themselves have obesity stigma is that it's a major barrier to them seeking help. And as I think I'll show you in the subsequent half hour or so of talking, doing it all by yourself in terms of losing weight and keeping it off really is not just a matter of lifestyle and personal endeavor. It does require medical help for most people. When it comes to health professionals, if the patient perceives that you have obesity stigma, that you're blaming them for their weight problem, they tend to have less trust in you. They're ultimately less likely to lose weight, and they're also less likely to engage in other preventative health activities. And practitioners themselves tend to be, understandably, if they think the problem is all the patient's fault, less willing to help with the weight problem. And I don't think any of that's a good thing. I mean, I think our job is to help our patients improve their health. And so even if you do feel that for some patients, they haven't done everything they could to help themselves, we should still make sure that we're non-judgmental when we're talking to them. Now, in both Australian and international guidelines, the recommended approach for obesity management is using the so-called 5 A's. And I'm not going to go through all of these, but I will mention asking, which is important. Most people, when they come to see me for kidneys or sometimes for obesity, but mostly for a kidney problem. I imagine when they come to see you, it's for a whole plethora of different reasons, but often not for weight management. But you see the patient and you notice that they have an excessive body weight and you want to discuss it. It is important to ask permission first, and that way you develop a better rapport with the patient. And you also discover, whether they're at a stage where it's even worth the preliminary discussions. The other thing I'd like to draw out from there is the need to agree on a realistic weight loss expectation. And that's important because a lot of patients and quite a few doctors have an unrealistic expectation of how much weight the patient might lose. And if everybody is thinking of an unrealistic target, which is never going to be met, it just ends in tears. The patient doesn't succeed, they feel that they failed, they may give up altogether, and ultimately not so good. So while the patient may have weighed 60 kilos when they were 20 years old, now they weigh 100, they're 40 or 50, and they'd like to get back to 60, that's really not a realistic target for them when coming to see you for help. In terms of assisting, you can certainly look at the ACT health pathways, which are available on the web, and that's quite useful for looking for ways to assist your patients locally. Now, I've got the next few slides on The Biggest Loser. So it's not really The Biggest Loser study. It was The Biggest Loser TV show. I didn't watch it when it was on, but it was apparently quite popular. And out of this TV show came a number of metabolic studies, which I think are very interesting. So during the show, they had about 20 participants who were all severely obese. And these people tried to lose weight on camera until they were voted off. So the maximum time on the show was 30 weeks. And during the time on the show, they all received an intensive exercise program of several hours a day, and they got advice on reducing their calorie intake. Now, these people on the show undertook far more exercise than the recommended minimum 150 to 300 minutes per week. They were doing a lot of high-intensity exercise. And you can all, even if you didn't see the show, you can predict what happened. I mean, it was a TV show, right? So they lost a lot of weight. I haven't had personally anyone that from lifestyle intervention alone has lost 38% of their body weight, but it can happen. And they lost an average of 58 kilograms. Now, that's not what's interesting. I mean, in a TV show, we expect amazing results. I think what's interesting is to look at why they lost weight and what happened to their metabolism at the time and in the subsequent 6 years. So these people were studied and they used double-labeled water, and I think they used indirect calorimetry as well to actually measure their energy use from exercise and from resting metabolic energy consumption. And so the exercise-related energy use, not surprisingly, increased by 80%, or about 400 kilocalories a day, which is a substantial increase over baseline. But their total daily energy expenditure actually fell by 800 kilocalories a day. And yet these people lost 38% of their body weight. So you can see from that the weight was lost almost entirely because of a reduction in calorie intake. The exercise was done, but the exercise is not what resulted in the weight loss. What about 6 years later? Well, as is the case for just about every weight management program based only on lifestyle, there was a lot of weight regain. And in this case, 6 years later, the people had regained 41 kilograms. And that still means it was actually a very successful weight management program, because to get 12% net weight loss after 6 years is better than any publication I've seen on lifestyle intervention. But these were highly selected people. They were quite well motivated. Yet despite this, they regained the weight. So why did they regain the weight? Was it just what a lot of people think, that they became lazier and went back to gluttony? No, it's not. So if you actually, when the investigators looked, these people were still exercising at the same sort of level they were at the end of the 30-week TV show. Their energy intake had risen a bit. So it had risen by about 400 kilocalories compared per day compared to what they were having at week 30. But this still puts them at about a 400 kilocalorie deficit below baseline. So they were on an energy reduced diet. They were exercising a lot. And despite that, they'd regained the majority of the weight that they'd lost. So what's happening here? I mean, it's a bit depressing for them, and it's a bit depressing for people that want to lose weight through lifestyle change. But the issue here is that, and I'll just put my laser pointer on, I think, yeah. So if you look at this diagram here, you can see that for most of us, exercise is a pretty small proportion of our daily energy expenditure, about 12% or so. So even if you double it, you're only getting it up to about 24%. And most people don't have time to spend all day exercising. The bigger proportion is this NEAT, which is non-exercise activity. And that's things like fidgeting and just wandering around, but not deliberately exercising. And the biggest part of your daily energy expenditure is resting metabolic rate, or resting metabolic energy expenditure. And what happens when people exercise more is that within short order, their resting metabolic rate falls. So the overall energy budget, as it's sometimes called, stays much the same. If you exercise a lot, you will lose some weight, and you will increase your overall energy expenditure, but not by very much because of this impact on resting metabolic rate. Now, there's an analogy here in these cartoons that I'm trying to draw between a car and a person. And I commissioned my son a couple of years ago to draw these cartoons for me. And when I show you a slide a bit later on that I drew, you'll probably see why. So if you take a car and you fill its tank with fuel, let's say it drives 500 kilometers and then it stops. The engine along the way is going at about 100, 110 degrees, and it keeps going until it's run out of fuel. If it had an auxiliary tank, perhaps it could go a bit further. You then take the same car, and instead of giving it a full tank of fuel, you just give it half a tank. It's now going to go 250 kilometers. Again, the engine's running at the same temperature. But its efficiency has not changed. It's using exactly the same amount of fuel to do what it's doing. But people are quite different. We're obviously not in appearance similar to cars, but in terms of our energy budget and how we consume energy, it's quite different. So there's a common mantra that you see that it's just energy in, energy out. You know, if people want to lose weight, you just have to eat less. Well, it is true that you have to eat less, but it's a lot more complicated than that. Most of us eat roughly twice the number of calories each day that we actually need to. And by need, I mean that you don't continually lose weight. So if you reduce your calorie intake, you lose some weight, and then you plateau and you stop losing weight, even though you've continued eating less. If you reduce it much less than half, then you will continue losing weight indefinitely until you die. Now, this person usually eats a full hamburger each day, and they get right through the day, and then they get pretty tired, as you can see here, and fall asleep. If the same person then decides, all right, I'm only going to have half a hamburger a day, they can get right through that day. They can get right through the next day. They will use some of their auxiliary tank, I guess, which is their fat reserves, to keep going. But as they go along, they'll need to wear more clothing because they'll be generating less heat from resting metabolic rate, and their overall daily efficiency will increase substantially so that they don't continue losing weight forever. They lose a few kilos and then it stops. So energy in, energy out is true, but it's not enough. And it's going to be very difficult for people to sustain a 50% calorie reduction for a prolonged period of time. So weight loss is certainly achievable with diet and exercise. The Biggest Loser TV show has shown that, and everybody knows it from day-to-day life. But what we also see is that it is virtually impossible to sustain a large weight loss just through lifestyle change. There are some people that achieve it, but the vast majority don't. Now, just to inform you, I guess, so an average, I've mentioned calories or kilocalories a few times. So in Australia, the average male eats about 2,300 kilocalories a day. Females a little bit less, on average 1,800. A very low energy diet, which is an OptiFast, OptiSlim type total meal replacement, that usually contains 800 to 1,000 kilocalories a day. A reduced energy diet, which is often prescribed by dietitians for weight loss as a lifestyle change, is usually about a 500 kilocalorie deficit, and a low energy diet is somewhere between the two. So what does the Australian government tell us? There's the Eat for Health website, which has advice on diet and on preventing obesity. And their first guideline suggests that to achieve and maintain a healthy weight, people should be physically active and choose amounts of nutritious food and drink to meet their energy needs, which is all very true and correct, and I agree with it. But I would point out that we don't actually eat to meet our energy needs. We usually eat for hunger. And hunger is not always representative of our energy needs. It's representative of what our body thinks we should be doing with our body weight. In guideline 2 and 3, there's a recommendation for eating more vegetables, fruits, and whole grains. Now, eating more of anything is not going to result in weight loss, but if it's combined with a reduction of other foods, in this case, less healthy foods, saturated fat, alcohol, added sugar, and salt, then there is the potential for benefit in preventing obesity. And I'll show you a bit more about that in another few slides. So that's to prevent obesity from the Australian government. What diet does prevent obesity? Do we know? Well, the answer is that we don't know for sure, but there is certainly a strong association between higher intake of what are termed ultra-processed foods and the development of obesity. So the prevalence of obesity has increased in concert with higher intake of ultra-processed food over the last 40 or 50 years. That certainly doesn't prove causation, but I find it quite incredible that today Australian children get on average more than half of their calories from ultra-processed foods. And there is quite a bit of evidence that ultra-processed food is unhealthy. And in a little bit, I'll show you why it tends to make us overeat. So that's for avoiding weight gain. What about diets to lose weight? Now, in this case, I don't have a TV show that's particularly useful, but there have been many publications comparing different types of diet for weight loss. And diets come and go frequently. Many of them have a person's name attached to them. At the moment, I think the more popular ones are probably time-restricted eating of one sort or another. I've pulled out here and listed 3 different trials. There are many others, but I think these are probably the better known ones, and probably the A to Z trial is one of the best known in the obesity world. So the A to Z trial did actually show an Atkins type diet, which is a low carbohydrate, high protein, high fat diet, worked better than all of the others, that being a low-fat, high-carb diet, and a few other ones that they tried as well. But the other trials didn't find that. And when you review all of the trials together, it was actually adherence to the allocated diet that predicted success. So it just so happened that in the A to Z trial, the Atkins diet was preferred by patients, and they maintained it more often than they did the other dietary choices. And for the other dietary studies, and in most of the other publications I've seen, that's not the case. So what I would take from this is that the willingness to adhere to a diet or to a lifestyle recommendation is what's most important for weight loss. Reduced energy intake is going to be critical. If you want to lose weight, you do have to reduce energy intake. The macronutrient content probably makes no difference. Now, there will be some people that respond better to one type of diet or another. We're not all identical. But in general terms, there's no need to specifically recommend a high protein diet or a low-fat diet. It's better to talk to your patient, which does take quite a lot of time, maybe refer them to a dietitian for added help, and work out what kind of diet is going to fit in with that patient's way of living. And what diet are they most likely to follow? And the one that they're going to follow is going to be the one that helps them lose weight. So I've mentioned ultra-processed food a couple of times. It's a newer term. The old term would be junk food, but they are slightly different. Whether it's a worthwhile term or not, I'm not sure. It might be out of favor in another few years. It was the NOVA definition, and that's not actually an acronym. The NOVA definition was coined by Dr. Monteiro in Brazil a few years ago. And I've summarized it fairly severely, but it essentially is food of industrial origin, food with a lot of additives. So an easy way of looking at it is often that if it comes in a packet and it doesn't require refrigeration and lasts a long time, it could well be an ultra-processed food. Ice cream, of course, is ultra-processed and needs a freezer. So there are foods that don't quite neatly fit in. And what's the problem with it? Well, I've told you that there's a strong association with weight gain in the community and with weight gain in individuals. But is it causative? Well, we don't know for sure, but there is some evidence that it probably is causative. So this was a small study back in 2019, and it was done in a metabolic ward in a hospital, so they could measure patients' energy usage, and they could be certain of what people were eating. And they randomized them to start with either an ultra-processed diet or an apparently equally palatable unprocessed diet. And people could eat as much as they want. When they were on the ultra-processed diet, they ate more calories. So compared to the unprocessed diet where they ate fewer, they had, maybe another 300 odd calories more on the ultra-processed food. And with that increased intake of calories, they gained a bit of weight, whereas on the unprocessed diet, they lost weight. Now, this was despite the diets having equivalent macronutrient content. What I find interesting about this is not only that people lost a bit of weight on an unprocessed diet, but it's speculating why they lost the weight. Because with most diets, or virtually every diet that promotes weight loss, it also promotes hunger. But in this case, the hunger scores were identical between the two dietary periods. So it seems from this that perhaps ultra-processed food just makes people eat more. And it does it without, in substituting an unprocessed diet can help you lose weight without necessarily activating hunger. So I've talked about diet to prevent weight gain, and we've talked about diets to promote weight loss. But of course, the only reason we want people to lose weight is so that they're healthier. And there are diets that can help you lose weight that may not necessarily be all that healthy. So the diet for overall health is also set out in the Australian Healthy Eating Guideline. And it is essentially to have a less processed diet without the saturated fats and things. I would agree with it myself in all respects, except perhaps on their comment that you shouldn't have a diet with added oils, because I think there is quite good evidence that adding extra virgin olive oil or tree nuts to your diet reduces cardiovascular mortality. However, I would agree that adding extra virgin olive oil or any other oil to your diet is not going to assist you to lose weight. So it's important to try and stick to a healthy diet. And I think when it comes to looking at weight loss, we need to move away from recommending a particular macronutrient content and towards types of food. And the type of food that's going to work best is a less processed diet. And the success is going to depend on whether it's adhered to by the individual. All right, that's enough of diets, I think. What about sleep? So there is an inverse association between sleep duration and obesity. And there is an association between sleeping for more than 7 hours a night and less weight regain after other interventions to lose weight. But again, as with the unprocessed diet, is this causative? Well, I think it is. And there is actually quite a lot of evidence from short-term trials only, though, looking at interventions to either sleep more or less. And in the studies of sleep restriction, patients consistently eat more. They tend to reach for high carbohydrate food and they eat more of it. But in this study that I'm showing you here, which was published very recently, this took a group of overweight young adults. They were about 30 to 40 years old, I think. And to get into the study, they had to have a habitual sleep time of less than 7 hours. And as it happened, their sleep time was about 6 hours. The aim in the study was to increase sleep time to 8.5 hours. And they randomized people to either that group or to no change in sleep time. And they tried to increase sleep time by essentially getting them to go to bed earlier. And it worked. They didn't get to 8.5 hours, but they did increase habitual sleep time to 7.2 hours per night. And what happened? Well, the spontaneous calorie intake was reduced by 270 kilocalories a day in the intervention group. So in this randomized trial, simply sleeping for an extra 1.2 hours a night led to a reduction in calorie intake. It didn't have any impact on energy expenditure either, so it didn't seem to affect resting metabolic rate, and it did lead to a small reduction in body weight. Now, a calorie-restricted diet of 270 kilocalories a day is not going to result in substantial weight loss in anybody, but I think this is very important to keep in mind when you have a patient in front of you who's gaining weight, and you're looking at what you can do to arrest that weight gain. Because 270 calorie excess per day, if you could eliminate it, may well be sufficient to avoid the weight gain. All right, now you get to see my drawing skill, and you can probably see why I commissioned my son for the other cartoons. So there's 3 panels here, and what I'm trying to show is how different interventions to lose weight affect people in terms of their body weight set point. So the higher somebody is in the pool of water, the heavier they are. And this person here on the far left panel was floating on the water like this gentleman here, but he decided that he was going to lose weight through lifestyle intervention alone. And he worked very hard at it, and he managed to lose the weight. But you can see that as soon as he lets up on his effort, he's likely to bob back to the surface again and rest once again at his body weight set point. And you'll have to imagine that he has a snorkel, otherwise, of course, it's not going to work. This person here is resting quite comfortably at an excess body weight level, and he decides that he wants to lose weight. So he comes along to see somebody who, of course, writes a prescription for semaglutide. Let's assume he can actually get hold of it. So he starts taking the semaglutide, and this lowers the water level. So it essentially makes him less hungry at a given body weight, and he will lose some weight in all likelihood. But he hasn't reformed his lifestyle. So perhaps he's not sleeping properly, perhaps he's engaging in a lot of non-hungry eating. Whatever the issue is, he hasn't fixed it. And that's just pouring in a rising set point at the other end. So while he may lose some weight, he is very likely to regain all of it and may actually continue gaining weight again after that. So what we want to do with our medical weight loss interventions is combine it with lifestyle. The aim would ideally be to allow people to lose weight with no effort, but that's not possible. The medical interventions lower the water level, they lower the set point or the hunger point predominantly, and then with less effort, people can maintain that weight loss. So I think this sort of strategy is going to be a lot more sustainable than this sort of strategy. The strategy in the middle is very easy, but it does not lead to good results. So although I've shown, I think in the previous slides, that lifestyle is not really the answer for sustained weight loss for many people, lifestyle is critical if we want to use medical interventions or other interventions to help people lose weight. So there are different interventions that you can have to lose weight, and they have a different impact on body weight set point. So body weight set point is made up of a number of things. One of them is hunger. The other is a related thing, which is the hedonic drive to eat. And hedonic drive to eat often moves with hunger, but it is separate. So the hedonic drive to eat is when you've been to a restaurant and perhaps you've had a very nice meal and you're comfortably full. You don't feel like having anything else. And then the dessert menu comes along. You see the chocolate pudding, or perhaps in my case, you might see caramelized pecans on the menu, and you think, I think I could fit that in. I could manage that. And so you order it and eat it. So that would be hedonism driving your eating. They do move together, but you can be non-hungry and still have that reward-based hedonic eating. So if you, and the third part of the set point is the resting metabolic rate. Now, sleeve gastrectomy involves chopping off most of your stomach and throwing it away. A little bit crude perhaps, but the stomach does produce ghrelin, which is a major hunger hormone. And when you do a sleeve gastrectomy, it lowers ghrelin. Whether that's important for the weight loss you see with a sleeve gastrectomy, I think is less certain, but it has that effect, and it reduces hunger, it increases the satiety hormones, and it helps people lose weight. If you look at a weight loss medication, they don't necessarily lower ghrelin, but they do all work by reducing hunger at a given body weight. Whereas if you use a calorie-restricted diet to lose weight, there is always an increase in ghrelin, and that increase is maintained, as far as we know, indefinitely, and it leads to an increase of hunger. So it makes it much harder to sustain the weight loss through hunger being increased. So a beautiful lifestyle alone usually does not yield adequate weight loss. It's good to have a beautiful lifestyle, but doing it may well prevent, and I would hope would prevent, most cases of obesity, but it is not going to yield adequate weight loss for most people. The average weight loss from a lifestyle intervention is only 3 to 5% in the long term. There are studies that have got better. They've got up to 8% weight loss, but that's unusual. And certainly you can't expect more than that from lifestyle. Having said that, an appropriate lifestyle is essential for long-term weight loss. Without an appropriate lifestyle, no medical intervention is going to be successful in the long run. And I'd like to remind you also that we don't have any treatment that will stop someone from eating. We have treatments that reduce hunger. We have treatments that probably reduce the hedonic drive to eat as well, which is, as I said, related to hunger. But if people are eating because they're lonely or because they're sad or because they're happy, we don't have a drug that will stop them doing that. And we also don't have any medications that will safely maintain a high metabolic rate. Now, you can certainly prescribe lisdexamfetamine or some other drug like that, but I personally wouldn't regard it as safe. All right, now we come to some of the iatrogenic causes of obesity, and really just drugs is what I'm going to talk about briefly here. So some people are not overweight or obese because they've had a bad lifestyle. Some people are overweight or obese because of drugs that we've given them. In my case, it might be prednisolone. In other cases, it's some of these drugs that are listed here. Now, not every drug here will cause weight gain in every person. So one person may be able to take mirtazapine and not gain weight. Another may be able to take valproate and not gain weight. And some of this could be predicted by doing some whole exome sequencing and genetic analysis, because there are particular genes or polymorphisms in the genes that are associated with weight gain. But that's not practical at a clinical level. So it's best to assume that these drugs will cause weight gain in anyone that you give them to. And unfortunately, once they've gained the weight, because it usually takes a few months, simply stopping the medication is unlikely to cause reversal of the weight gain. Now, in some cases, you have no choice. So if somebody has severe schizophrenia, they're going to need perhaps clozapine. I'd defer to Louise on when to use that. I certainly wouldn't prescribe it myself. Or some of the other antipsychotics. If someone has severe epilepsy, they may require valproate. But often there is a substitute for their drugs in this category. And depending on the indication, there's often another drug you can use rather than a beta blocker. Now, if you have somebody that you or someone else has started on an obesity promoting medication and they have an issue with the weight, although stopping the medication won't likely return them to their previous weight, attempting to stop the medication is still very useful because it makes other weight loss interventions more effective. So still try to get them off it, but don't necessarily anticipate perfect success. So my conclusion here is that primary care has a key role in helping patients avoid weight gain. You're seeing patients repeatedly. You can monitor what's happening to their weight. And if you provide evidence-based, non-judgmental advice to people who are gaining weight, I think there's a real chance of helping avoid further weight gain. Medical support will be needed for most patients that have developed obesity. Some will lose enough weight through lifestyle alone, but the majority will not, and they'll need further assistance in that, which is going to be discussed in some of the subsequent talks in this series. Specialist support is helpful for those that have significant comorbidity. But really, to actually fix obesity in the community is going to require a cultural or environmental change. I suspect to reduce the amount of ultra-processed food that we eat, to sleep more, to exercise more. That's something that I certainly can't achieve, but it is what's going to be necessary to help obesity at a society level. So now I will stop sharing and I return the floor to Leonie.
Hi, that was really interesting. Thanks, Richard. I've scribbled down quite a few questions, so I'd encourage other people to put some questions up, but otherwise I'll just monopolise the Q&A session, which doesn't seem quite fair. So I thought your drawings were fantastic, and also your son's drawings were fantastic, so thanks for sharing them as well.
I'll pass that on. Thank you.
Okay, so now moving on to Louise. We're very lucky to have Louise with us tonight. And Louise is a psychiatrist at the Canberra Obesity Management Service. She has a background in public health and chronic disease management and has spent the past several years working in remote Central Australia. Louise also has certification from the Strategic Centre for Obesity Professional Education, like Richard, and also postgraduate qualifications in forensic mental health. So thank you very much, Louise.
Thanks, Leonie. I'll try and share my screen now. Just bear with me, please. Okay, I hope everyone can see the slides. So thanks for having me. Today I'm going to talk about the psychological and psychiatric aspects of obesity, and hopefully it might provide some new insights or build on your existing knowledge of this really complex subject. So the learning outcomes for today are to identify the complex relationship between obesity and mental health, understand how attachment difficulties and developmental trauma can lead to obesity or predispose to obesity in later life, and outline the most common psychiatric comorbidities in obesity. So obesity and mental illness, it's a very complex relationship. I guess you could look at it from the perspective of, was it the chicken or egg causality dilemma? There are a lot of factors that, bidirectional factors that link these two diseases. And there's an interplay between genetics and environment, as well as iatrogenic causes, like Richard had just said, particularly certain medications, and also motivation and cognition. Other factors that need to be considered are dysregulation of mood and the HPA axis, as well as other metabolic derangements and the role of inflammation, both in mental illness and obesity. So this is a table from a recent systematic review and meta-analysis looking at the prevalence of certain mental illness in patients with obesity. And as you can see, depression was the highest one there, followed by binge eating disorder. And so what's known is that the greater the severity of mental illness, the greater the risk of developing obesity, and also the more likely that the BMI will be higher, and that the patients are more likely to suffer with increased number of medical comorbidities. So comorbid obesity and mental illness has been demonstrated to be associated with a reduced quality of life, increased disability, increased morbidity and mortality, and people with serious mental illness usually die on average 15 to 20 years younger than their age-matched counterparts who don't have a mental illness. And then that's compounded when people have obesity, and that's predominantly because of metabolic illness. So I'm just going to sort of start back at the beginning, and we're going to talk a little bit about attachment and trauma and how that can impact on obesity. So as many of you probably already know, secure attachment is important for relationships and interacting with others, regulating your emotional state, responding to stress and problem solving. So insecure attachment can occur when an infant is exposed to non-validating environments in the early days, weeks and months of their lives, and years in fact, and low parental responsiveness. So if people have an insecure attachment style, it can lead to attachment difficulties, and it can actually impact in terms of how people help seek or how they manage their health as an adult. So for example, particularly for people working in primary healthcare, you're often on the front line and dealing with people as the first port of call. So people with an anxious, insecure attachment style are more likely to report an increased number of symptoms and have recurrent presentations. And it might be that you might feel as though you can't actually satisfy or help these people as much as you'd want to help them. In contrast, people with an avoidant attachment style are less likely to seek health care. They don't utilise their health system enough, and they don't report or they underreport their symptom severity and the amount of symptoms. So that can obviously lead to worse chronic health conditions as they age. Communication is also in fact impacted by insecure attachment, and this can lead to challenging interactions between health staff and patients. So you might be able to recall some of your own experiences where difficulties with communicating or trying to help satisfy a patient in terms of their demands or expectations, and it can be very challenging. Also, any attachment difficulties or early life trauma can impact on stress regulation, and that's primarily linked to the HPA axis and the autonomic nervous system. So early life trauma, or what we now sort of refer to as developmental trauma, is closely linked to obesity. Some people like to view developmental trauma in two ways. So the physical and sexual abuse, a very severe, significant trauma. But as you know, there are lots of other types of trauma that can occur, and particularly abuse of children in terms of neglect and emotional abuse. And people may be familiar with the Adverse Childhood Event Survey, which lists how some of these things can impact on people's functioning in later life. The strongest relationship has been seen between obesity, early life trauma, and binge eating disorder. So you can see how it all sort of comes together, and the trauma can then impact on how people might eat, which then may also lead to obesity. If we think about binge eating disorders, it's usually considered to be a maladaptive coping strategy to self-soothe or to manage stressful situations or interpersonal conflict. It's some people describe it as a comfort eating or emotional eating. Some people have the insight to recognize that, yes, they're responding to their emotional state and that's why they eat or overeat or binge. And there's some experts that actually propose that binge eating is a form of self-harm. So early life trauma can predispose to personality vulnerabilities. So again, that can manifest as interpersonal difficulties, relational difficulties, poor self-worth, including a poor body image, and it can also lead to self-harm and suicidality. Interestingly, some people who have obesity, although they have a poor body image, they also embrace the fact that they have a larger body habitus because they feel that in some way it might protect them. So if they do have a history of significant trauma, they feel that a larger body, people have described it as they have a perception that they might be less attractive to other people and therefore less likely to draw attention from assailants. Also, some people with obesity who have that trauma background have noted that their large body allows them or gives them the confidence to fight off any assailants that might approach them. So in a way, it's protective in their minds. So this graph just shows how with increasing BMI, the incidence of depression also increases. And now I'm just going to talk about a couple of, or 4 different types of mental illnesses that we can see in obesity. I'll start with mood disorders. So especially in primary care, you've probably come across people with obesity that also have a comorbid mental illness, and in particular mood disorder. And you might have noticed that it can sometimes be quite tricky to treat. So what the latest evidence shows is there's a strong bidirectional relationship. So is it the obesity that causes a mood disorder or vice versa, or a bit of both? And my next slide will sort of elaborate on that. So major depressive disorder is more common than bipolar disorder in obesity, but they both do occur quite commonly. Prevalence rates vary. So a recent systematic review found that 32% of patients with obesity had a mood disorder. Interestingly, the Obesity Management Service did a study a few years back. It was just a small retrospective review, but the percentage of comorbid depression in that study was 30%. So that's sort of consistent with the literature. In patients who are undergoing bariatric surgery or preparing to undergo bariatric surgery, the rates are estimated to be lower, but still relatively high, around 19%. So risk factors for developing a mood disorder in conjunction with obesity include environmental, so psychosocial stress, an unhealthy lifestyle, and the early life trauma, as I mentioned. Also dysfunctional metabolic systems, so alterations in the HPA axis, the endocannabinoid system, and also inflammatory states. Variations in brain substrates. So we know that certain neurotransmitters are responsible for reward, motivation, emotion, and cognition. So if we think about dopamine and serotonin circuits, which a lot of the antidepressants target, For people in obesity, there's actually reduced dopamine receptor availability. But there's a high sensitivity to high calorie foods without a corresponding, I guess, a negative feedback loop in terms of reward and feeling satiated. So the endocannabinoid system, that is involved in energy metabolism. And what studies have found is that in people with obesity, there's reduced cannabinoids, and that can lead to depression, anxiety, and suicidality. I'm not sure if people have heard of this. It's a fairly new concept, but some experts are proposing a metabolic mood syndrome. And I'll talk about that in a bit more detail after this slide. But this slide, I think, is a nice representation of that chicken and egg concept. So we can pick a side to start. I guess I'll start on the left with the obesity. So if we think about obesity, we know that it causes dysregulation of the HPA axis and that it causes a low-grade chronic inflammatory response. So those two things can lead to mood dysregulation, which can then lead to a depression. But having a depression can also lead to dysregulation of the HPA axis and an inflammatory state as well. So very similar in that regard, which then leads to metabolic derangement, and it can just be a vicious cycle that goes around and around. So thinking about the metabolic mood disorder, so it's not a formal psychiatric diagnosis, it's not in the DSM-5, but it's just something to keep in mind. And here are some examples. So with a major depressive disorder in a patient with obesity, the illness tends to take a more chronic course compared to patients without obesity. They're more likely to have frequent episodes or relapses, and their symptoms are more likely to be atypical in nature. So unlike some of the other depressions where people might have a reduced appetite and lose weight, people with obesity and a major depressive episode may actually have increased somnolence and an increased appetite. There's also an increased risk of suicide and cognitive impairment when a major depressive disorder is occurring with obesity. In regards to bipolar disorder, they tend to have more predominant depressive phases compared to the people with bipolar disorder without obesity. So these depressive phases tend to be much longer in duration and are a lot more difficult to treat. People will often end up in hospital for management of a prolonged depressive phase. And interestingly, they are less likely to respond to mood stabilizers, or only maybe partially respond to mood stabilizers. So they're things like lithium and valproate. And as Richard mentioned earlier, sometimes we know that those medications can cause weight gain, sedation, increase hunger. So sometimes it's not appropriate to remove those drugs, but I guess it's something worth considering if people aren't really responding as well to those drugs as you would expect. So anxiety disorders are often overlooked in obesity, and I think in general as well. The prevalence estimates of anxiety in patients with obesity range from 12 to 24%, and a lifetime prevalence with comorbid obesity can be up to 37.5%. Anxiety rates tend to remain unchanged post-surgery. And there's a meta-analysis that has shown that there's no association between anxiety and post-surgical weight loss. It's important to note that we'll talk about this more in the second and third webinars, but having bariatric surgery and losing weight doesn't necessarily improve a coexistent mental illness. So it won't necessarily reduce anxiety, and it's not necessarily going to improve mood, and in some cases it can actually worsen with weight loss. I'll briefly touch on eating disorders. So I think as well, this is only really coming to light more now that obesity is more in the spotlight as well. So binge eating disorder is a relatively new diagnosis. It was introduced into the DSM-5, but essentially that's the most common eating disorder among patients with obesity. For those of you that aren't familiar with it, it's recurrent episodes of binge eating or eating large amounts of food in a short period of time. And there's some certain additional criteria. So it may be eating fast or eating when not hungry, losing control when eating. That's a very common one that I come across at the Obesity Management Service. There's also eating alone or eating secretively because people feel embarrassed, and also feeling guilty or disgusted with themselves after the binging episode. And I'll just highlight that word disgusted. It's such a harsh word, but people, when you ask them, they often nod and go, that's exactly how I feel. So it's an interesting disorder. There's a certain there's severity scales as well, and that's based on how many binge eating episodes they have per week. Night eating syndrome is another common eating disorder that can occur in people with obesity. So that's where people will go to sleep and then wake up and then intentionally go and eat food. That's different to maybe a sleep eating syndrome, where people might not be aware that they're eating food or trying to cook food through the night. Night eating syndrome can also present as someone who's had an evening meal and before bed will binge on food just prior to bed or have a large amount of food. So the prevalence of these disorders vary, and I think in part that's due to how data is captured or how disorders are culturally determined or accepted. So there's some cultures where people do want to eat or they're expected to eat large amounts of food. So it is hard to really determine the prevalence. Sorry, my cat's howling. I hope that's not distracting anyone. With the higher BMI, there's an increased prevalence of night eating syndrome. So unlike anorexia nervosa and bulimia nervosa, the age of onset is usually later for binge eating disorder and night eating syndrome. The gender differences are less pronounced, but they can occur together. They both cause distress, and that's one of the diagnostic criteria for both of them. However, night eating syndrome doesn't seem to cause as much guilt and remorse as the binge eating disorder. So in terms of why binge eating disorder and night eating syndrome might lead to weight gain or lead to difficulty losing weight, they say that it's mostly the loss of control that's seen with binge eating disorder as a way to not be able to lose weight or to continually gain weight. Whereas with the night eating syndrome, it's more related to the delayed nocturnal eating patterns. And with those eating disorders, you can expect to have higher rates of depression, anxiety, personality disorder. So substance use disorders are an interesting group of disorders in obesity. So they've done some studies in patients undergoing bariatric surgery and found that up to 35% of those patients may have had a substance use disorder, or prospective studies are showing that people may develop a substance use disorder after the bariatric surgery. The most common substance use disorders in obesity are alcohol and tobacco. Interestingly, the prevalence at the time of people undergoing bariatric surgery is a lot less, so 1 to 8%. So some people argue that that might be underreporting because people are so invested in having the surgery that they may be downplaying the extent of their substance use. But I also think there's a role there for identifying these substance use disorders earlier, and sometimes it's by identifying them well in advance of the surgery, then people can receive the support they need. They can talk about it openly so that when they do undergo the bariatric surgery, they are going to have improved outcomes. And so similar to the binge eating and the mood disorders, the higher the BMI, there's a higher rate of substance use among that population. So the risk of developing a substance use disorder can actually increase after bariatric surgery. And people propose that it's the concept of addiction transfer. People may have heard of that. So that's where someone shifts from one particular substance to another. So for example, moving from binge eating, and then after a sleeve gastrectomy, there is reduced space to have food, and people are still looking for that high that they might be getting or had previously got with the food. So they might transfer it to another substance. And we often see that with alcohol, and I'll talk about that in a little bit. But essentially, it's if people are using binge eating to self-soothe or as a comfort measure, it's a maladaptive way of managing negative emotional stress. And so what we hope to do at the Obesity Management Service is address these things earlier, so that following surgery, there's a less chance that people will struggle and turn to other sort of maladaptive strategies of coping. So just with alcohol, as you know, it's a very energy dense and nutrient poor substance, but it's very easy to consume after bariatric surgery because it's in a liquid form. And also after surgery, there's an alteration in the metabolism of alcohol, more so with some bariatric surgeries compared to the others. But with that, you get an increased alcohol sensitivity, which means people don't have to actually drink as much, but they're getting that positive reinforcing effect. And so if people are consuming large amounts of alcohol post-surgery, even if they have a nutritious calorie controlled diet, that can lead to weight regain and a sense of failure. So I may have gone too quickly through those slides, but so the next time I'm going to speak is in the third session, and I'll talk a little bit about some of the treatment options for mental illness in the context of obesity. So we'll look at medication choices and whether it's useful starting medications or switching, ceasing, looking at the risk-benefit analysis of either starting or ceasing psychotropic medication, and also looking at some non-pharmacological strategies. And that's really important for some of the mental disorders that don't respond well to medication. So things like complex PTSD, personality disorders, and some eating disorders. And I just thought I would also bring your attention to the new the National Eating Disorder Collaboration Clinical Practice Guidelines. So they are on your Health Pathways website. And this is a new guideline that's been produced for eating disorders for people with a higher weight. And so this is actually quite helpful, and especially I think for primary care. And there's a focus on trying to actually identify eating disorders, including binge eating disorder among patients with a higher weight. What they're saying is that often in a primary care setting, you might have people coming to you asking to lose weight, but in fact, there might be an underlying binge eating disorder that is really going to hamper or hinder any efforts to lose weight unless that's addressed. So that's a really good resource. And thanks for your time.
Thank you very much, Louise. So I just have to ask you, is your cat hungry or has it got energy needs? Is it energy being met?
He wants to come inside. So,
okay, so it's nothing to do with appetite. Yeah.
No, I've got him on some Saxenda.
Okay. Okay, so what I thought we'd do now is maybe we'd give each of the panelists about 5 minutes, so starting with Richard. And thanks very much, Louise. That was really good. I've got some questions too. But give Richard and Louise 5 minutes each to go through their poll questions. And I noticed on the chat that some people found it a bit distracting reading the questions and paying attention to the presentation. So we'll kind of finesse that for our next webinar. But so Richard, would you like to start first with your questions?
So the first question was a patient new to your practice sees you for gout in his big toe, weighs 100 kilograms, height 1.8 meters, blood pressure 150/93 and BMI 31. What's a good next step? And most people said provide advice on treating the gout and ask permission to discuss his weight, which I think is the correct answer. Some people thought providing advice on treating the gout and refer to a dietitian for a very low energy diet. So a very low energy diet, could well be a good option for him, but I wouldn't leap into it. There are, in my opinion, there are a short-term way of losing weight. And if you don't have a strategy that's in place for dealing with the weight regain when they pop out at the end of 3 months, then they're not that useful to use. So I tend to use a very low energy diet in people where I need rapid weight loss. So people that have very poor diabetic control and they're on huge doses of insulin, I think a VLED is good there. And the other group is where there's just very resistant hypertension due in part at least to the excess body weight. And we try to get the weight down so we can get them off some of the drugs. And then some people also provided advice about the gout and let him know that he should get back to exercising again as soon as the pain has subsided, or he will get fatter. So I think that answer is also in a way correct, but I don't think it's as correct as the second answer, because according to the 4 A's, we should certainly start by asking permission. So question 2, which is the most correct with respect to exercise and body weight? And this has a more even distribution of answers. No one thought that just if you exercise more, there'd be less time for eating weight. The majority of people preferred that maintaining over 300 minutes a week of exercise is associated with less weight regain, and that's certainly correct. Some people felt that most obese patients have much less daily energy expenditure from exercise compared to the non-obese. That's true if you're looking at elite athletes, and it will be true amongst some people with obesity and some people without obesity, but in general, it's not. There are obese people who do a lot of exercise and they remain obese. So I wouldn't, and I wouldn't agree with the second part that if they increase their exercise to a more normal amount, they'll get clinically significant weight loss. Because in fact, as I hope I showed during the talk, exercise is pretty ineffective for weight loss. And then this answer, the last one about exercise contributing 40% of daily energy intake, is also incorrect. And again, in the talk, I think I showed that it on average is about 12% of energy expenditure. Question 3. A normal calorie intake for Australia is 2,500 kilocalories a day. Which of the following is correct? So a few people thought that a 2,000 kilocalorie diet would result in ongoing weight loss, which is incorrect. You will get some weight loss from a 500 kilocalorie reduction in diet, but it's unlikely that you'll be still losing weight after 6 months. 1,000 kilocalorie diet would be a very low energy diet, VLED, and that is an excellent short-term strategy for losing weight, but you cannot use them in the long term. The option C, the VLED, is useful when rapid weight loss is necessary, but should not be continued in the long term. So that is correct. They're only supposed to be used for 3 months at a time, and then you have a break, and then perhaps you go back on it again. And then some people felt that a 2,000 kilocalorie energy restricted diet would result in ongoing weight loss after 6 months if patients did 150 minutes a week of moderate intensity exercise. And I think that's also incorrect because the exercise itself is not going to cause a great deal of weight loss. And 150 minutes is really at the bottom of what people would need to be doing to prevent weight regain. To prevent weight regain, you really need 300 minutes. And I think you can see that from the outcomes of those Biggest Loser study papers. All right, so this one's talking about the Australian Healthy Eating Guide, and most people selected the correct answer. I think that one was relatively straightforward. The second answer, 37% It's a bit odd. They don't seem to add up to 100%. But the second choice, where you should increase intake of whole grain and reduce high sugar foods such as fresh cherries and cola. So it's not recommended there to reduce fresh cherries, only the cola. So drinks that have added sugar rather than natural sugar. And no one fell for the Himalayan mountain salt one. Ultra-processed food in question 5 likely increases the risk of obesity because, and the majority of people chose that people eat more of it than they do from unprocessed food. And that is correct. So there's a study showing that, which I presented to you. It probably does, well, it certainly does alter your microbiome as well, but I'm not aware of data that reduces your resting metabolic rate. And there's no known impact on energy expenditure when exercising. So question 6, which is correct with respect to weight loss medications? And most people said they will often result in short-term weight loss in the absence of a healthy lifestyle, but long-term results are poor, and that is correct. Few people thought that they wouldn't result in even short-term weight loss, which could also be correct. But I have seen a number of people when I give them, when you could get it, semaglutide or dulaglutide, and they have a pretty terrible lifestyle and you're using it more for diabetes, but they still lose a bit of weight. So sometimes people will, even without the lifestyle intervention. The next one, where they should not be used in the absence of lifestyle because patients should put in effort themselves. I sort of disagree with more on philosophical terms. I don't think that's why we want people to have lifestyle change. It's not because effort is character building, or it's because they need to get good results. And the last answer is not correct. So semaglutide has no evidence of increasing the risk of pancreatitis, and neither does dulaglutide. And the final question, for the last 6 months, a 25-year-old woman with metabolic syndrome has been doing 150 minutes a day of exercise, which is a lot. She's cut out all junk food, and she wants to know why she hasn't lost any weight and what she should do next. And just about everybody selected congratulate her on maintaining weight stability, assess her current diet in more detail with a view to starting a more restrictive diet. So a more restrictive diet is certainly going to result in more weight loss. And this answer here, to increase the exercise even further, I think, although it's obviously a bit of a typo because this is 300 per week and the question was 150 per day. But if we assume they're both a weekly exercise amount, increasing the exercise amount is not likely to lead to noticeable weight loss. You may get 1 or 2 kilos. I think you're probably not going to see 5, although it's possible. And nobody picked any of the other options, and I would agree that the other options were pretty silly.
Okay, thank you very much, Richard. So we might move on to Louisa, and if Louise you could go through your questions, and then we've got time for a couple of questions from attendees, and then we'll wrap it all up.
Sure. Am I able to get the poll results like Richard did?
I'll try, and I'll just click on it for you, I think. Yeah, how's that?
So,
Okay, view results. How can developmental and or attachment difficulties manifest in adults seeking healthcare? So 2% said increased help seeking in terms of the others. 7% was avoidance, 4% was difficult or challenging interactions, but the majority said all of the above. So well done. Question 2, what types of mental disorders are most common in people with obesity? So 89% said mood disorders, including depressive and bipolar disorders. actually, those percentages may not be right. That doesn't add up to 100. But anyway, so some people said anxiety disorders, some eating disorders, so an even spread on the other ones. But the right answer is mood disorders. That's the most common, followed by binge eating. So really depression and then binge eating disorder.
It looks like we've lost Louise for a little bit, so we'll give her a couple of, oh, she might be back now. Louise, are you there?
We can start with the questions. I can share
Okay,
the
sure. This question I think might be for you, Richard. The question is, does exercise help by building muscle mass, and does the increased muscle mass raise the metabolic rate?
So there have been studies, done where people do a lot of resistance training in order to try and maintain their lean body mass, because as you lose weight from any cause, from semaglutide, about 40% of the weight loss, for example, with semaglutide is actually lean body mass. So exercise has been proposed that if you increase the muscle mass, that will help minimize the loss of resting metabolic rate. And it probably does help. In fact, I'm pretty sure it does help, but it doesn't compensate for what's called metabolic adaptation. So when somebody loses fat mass, that also has some metabolic energy consumption. But if you take someone, say, that weighs 60 kilograms and has always weighed 60 kilograms, they use, X number of calories a day. Of resting metabolic rate independent of exercise. If you take someone who weighs 100 kilograms and they lose weight to 60 kilograms, they won't require X kilograms a day. And the difference, there will be less than X. And the difference is metabolic adaptation. And unfortunately, that occurs irrespective of how much exercise you do.
Okay. So because Louise is not here, I might do another question for you, Richard. So this is a question close to my heart. Why do women in their approaching menopause or after menopause find it so hard to lose weight?
So I could just simply say I don't know, but I'll expand a little bit. And I remember you saying something similar to me when we were talking about setting these talks up. And I had a slide which I took out, and it does show that it's certainly not due to a change in resting metabolic rate, because there are some studies that have looked at in thousands of people at their metabolic rate using double-labeled water, and there's no particular change at menopause. So there is a fall off, I think, after about age 70, but that's well after menopause. So it's not that, but I don't know what it is.
Okay, thanks. We've got Louise back now, have we, Kunal?
Yes, she's back.
So Louise, you want to go back to your polls and your questions?
Moving on to question 3. What are the proposed pathophysiology pathways linking obesity and depression? So a few people chose HPA dysregulation, inflammatory states, metabolic derangement. A few chose mood dysregulation, but the majority chose all of the above, which is the correct answer. Question 4, what is the relationship between obesity and depression? And there were 2 correct answers here. So it was the second response and the 4th response. And so again, 41 out of 45 people chose the second response. So that's good. So increased severity of obesity can lead to an increased risk of depression. And most people with obesity do not, in fact, have depression. And then finally, question 5 was which eating disorder, hold on. Which eating disorders are most common among people with obesity? So the majority of people chose binge eating disorder with no compensatory behaviours. with no compensatory behaviours. A few people did choose bulimia nervosa, so binge eating with inappropriate compensatory behaviours. You will come across people with a bulimia nervosa that do engage in purging activities like vomiting or using laxatives or other compensatory mechanisms like increased exercise. But the difference is in people with obesity, binge eating disorder is far more common.
Okay, thanks, Louise.
Thanks.
So just in the chat, someone has said that Jean Hales has a fact sheet on weight gain and menopause, so that might help answer that question as well. We've probably got time for one question for Louise, and then we might wrap it up. So just to paraphrase, we have a question or a statement from a person who had a gastric sleeve 5 years ago and found the post-operative experience not great in terms of support, and she particularly mentioned psych support and was wondering, is there any more literature now available for people who are considering bariatric surgery and post-surgery support, particularly psych support? So can you read that question as well, Louise? If you click on Q&A.
No, I can't see it, but I can answer. So it's really important to have that post-surgical support, and really, ideally, that should go out to 5 years. But in reality, there are limited resources to provide that level of support in the private sector. Unfortunately, it's a much-needed area. In the UK and Canada, there is quite a growing evidence-based and a lot of specialty services that provide bariatric psychiatry services. And so there's a lot of questionnaires, validated questionnaires, and support, ways to support people as they come to terms with that weight loss, because there's a lot of expectations on people in terms of that they put on themselves in terms of wanting to lose weight, but you've also got the expectations of others and how that might change over time, reactions of others, and also just trying to deal with the physical changes. It can be quite overwhelming. And if people do, this may not be the case for this person, but if people do have a trauma history and then they do lose the weight, it can suddenly cause a relapse in some of those triggers and reliving symptoms as well. So there's definitely a need for psychiatric support and all sorts of support for a longer period of time after the surgery. I think in the private sector, I don't know of any bariatric psychiatrists like they have in Canada and the UK, but hopefully that will change in the coming years in Australia.
Okay, thanks so much, Richard and Louise. That was really good. And I'm sorry we didn't get round to all the questions in the Q&A box. Maybe people can kind of contact us or ask those questions separately. But we better wrap it up now. So thank you all so much for coming, and thank you to the presenters. We'll send out the evaluation survey and the attendance certificates shortly. And also just to let you know, of course, that the Capital Health Network YouTube channel will have this a recording up soon. And to flag health pathways, the obesity management health pathways, which are going to be updated shortly as well. And just to reiterate, we can upload the 2 hours of education activities CPD to the RACGP if you have given us your RACGP number and also completed your evaluation survey. And please also feel free to upload yourself, self-record yourself 30 minutes of reviewing performance. Our next webinar in the series will be on Tuesday, the 21st of March at 6:30. So Tuesday, the 21st of March at 6:30, and it will cover obesity screening, comorbidities and complications. And the presenters will be Dr. Deborah Inman and Dr. Louise Brightman, who is with us tonight. Thank you, Louise. So be sure to register for that when we send out the invitations and pass the details on to your colleagues. And I think that's all for tonight. Thank you.
Louis, just a quick question. Have we going to skip the Q&A session? There is a Q&A. There's 6 questions in the Q&A.
Oh, yes, for me.
Yeah, there's 2 further questions. So one of them was, can you define the difference? I was going to move on because it was 8 o'clock and I thought we had to wrap it up. But there were 2 more questions. Can you clarify bulimia nervosa versus binge eating disorder and compensatory mechanism? And then there was another question about the role of the gut biome. But if people are happy to keep going, we can keep going, but it's 8 o'clock, so I thought people might want to end it there.
I'm happy to talk a little bit about the difference of bulimia and binge eating. I might have sort of answered that when I was going through the other, going through the quiz results, but essentially with binge eating disorder, there's no compensatory behaviours. So it is the large amounts of food in a very short period of time, feeling that loss of control, but then not having, not self-inducing vomiting or using laxatives or anything like that. Whereas bulimia nervosa, that's where people, they might eat normal amounts of food or they might binge and then they use the compensatory behaviours. So they're essentially not going to be absorbing the foods that they've, or not all of the food that they've ingested.
And I think that there is a little bit of demand on the chat for maybe Richard to address the gut biome question, if that's possible.
So I'm not an expert on the gut microbiome, but it's obviously a pretty topical area. And I'm sure it has a role because it seems to have a role in many diseases. But if you think about what diet that I've suggested is probably best for avoiding weight gain, which is an unprocessed diet, that will have a dramatic impact on the gut microbiome. And it's actually probably only by changing your diet that you're able to change your gut microbiome, or taking antibiotics, I suppose, but that's in a negative way. So essentially that's a prebiotic diet, an unprocessed diet with fiber and stuff to feed all the good bugs, rather than, you know, an ultra-processed McDonald's type diet. So whether it's the gut microbiome that leads to a reduction in calorie intake or not, I don't know. It certainly could be, because there's numerous links between the gut and the brain in terms of hunger signals and satiety signals. And I suspect, yes, that you're right, there is a role for the gut microbiome. And I think we address it by having an unprocessed diet.
Thanks, Richard. And there was just one question in the chat section about the self-reflection questions. So the reflection questions were the ones, or the ones that we answered throughout the poll. The evaluation surveys will be sent out shortly by Capital Health Network. So thank you very much.
Thank you.
Thank you, everyone.